Hi guys. For those of you who don't know, I'm Iulia. I'm one of the TAs for Psych 337. I'm going to do the final exam review. I'm just going to wait a little bit for other people to join. Okay, looks like people are joining now. Hi guys. Okay, so I got quite a lot of questions. I'm just going to start right away with answering them. So the first question is, I couldn't find recurrent depression in the DSM-5. In the definition set in class, it's more than one episode over time, but I was wondering if there's a diagnostic criteria for it. I couldn't find a subtype in the diagnostic criteria. So there isn't a specific recurrent subtype of depression in the DSM. It's not a distinct disorder from major depressive disorder. There's no separate diagnostic criteria for it. But if you're going to give someone a diagnosis for major depressive disorder, you code based on whether the major depressive episode is a single or recurrent episode. So you specify when you're recording the name of the diagnosis, this individual has major depressive disorder, recurrent episode, and then you specify severity, remission, and so on. So this type of MDD was identified because recurrent depression seems to be distinct from single episode depression. And this allows people to talk about more homogeneous groupings. The more recurrences people have of major depressive episodes, the higher the rates of depression and their outcomes, the worse their course over time. So every episode gets worse. So that's basically why we talk about recurrent depression. It's not like a separate thing in the DSM. It's just a way to be more specific about the illness that you're diagnosing or talking about. Next question. Is there a difference between chronic major depression and persistent depressive disorder? In the DSM-5, persistent depressive disorder combines formerly known DSM-4 categories, chronic major depression and dysthymia. And the slides are presented as two separate things, so can you please clarify what the difference is? Okay, so they are two different things. Basically, chronic MDD is MDD that's long-lasting. So if you're gonna say that someone has chronic MDD, that means that they have had at least one major depressive episode that has lasted at least 2 years. The course tends to worsen over time for chronic MDD. So it's just that people who meet criteria for MDD, if they have a major depressive episode lasting a very long time, at least 2 years, they get the label of chronic MDD. It's not a separate DSM category. On the other hand, persistent depressive disorder is sort of like slightly milder chronic depression. It comes on slowly, and a lot of the times people with persistent depressive disorder will just say that like they don't really know what it's like to not feel sad, to not be down. This is just how they are as people, how they've always been. And you can have double depression. So sometimes people will have persistent depressive disorder. So say like this is the baseline like mood for someone without depression or persistent depressive disorder. Someone with PDD might have their baseline like down here, so they're feeling very low a lot of the times. And then sometimes they might dip even lower into a major depressive episode. So you can have chronic MDD as well as persistent depressive disorder. You can have persistent depressive disorder with a major depressive episode. So the DSM-4 had a specifier for MDD that was chronic MDD. This is no longer an official specifier in the DSM-5, but again, it can just be clinically useful to know that a major depressive episode is chronic. So I think that's what that meant. Okay. And they are different. So I'm just going to briefly go over some criteria for MDD versus criteria for PDD. So for MDD, you need at least depressed mood or loss of interest or pleasure, as well as 4 or more of significant weight loss or weight gain, or decrease or increase in appetite, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness or guilt, diminished ability to concentrate or indecisiveness, and then recurrent thoughts of death. So those are the criteria for major depression. But then on the other hand, for persistent depressive disorder, it's slightly different. So criterion A says that for at least 2 years, people need to have experienced depressed mood for most of the day, most days are not. So this is actually one difference. With major depressive disorder, you need to see depressed mood or loss of interest. So to diagnose MDD, you can have someone who has just loss of interest and not depressed mood, versus PDD, they need to have depressed mood for at least 2 years. And then for persistent depressive disorder, other than that A criterion, you need to see the presence of 2 or more of poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration, and feelings of hopelessness. So there is a lot of symptom overlap, but they are slightly different. You can be diagnosed with both. Yeah, so those are the differences between chronic MD and persistent depressive disorder. Okay. So next question is, in my notes, I have that the short allele of the serotonin transporter gene is associated with slower reuptake of serotonin, and that it may represent a potential risk factor for depression. Isn't having slower reuptake of serotonin a good thing? Isn't that the whole point of treating depression with SSRIs? They inhibit serotonin reuptake, making it more available in the CNS. And there was a related question, so I'm just going to address both at the same time. The other question was, shouldn't slower reuptake link to better mood? Why does slower reuptake of serotonin lead to more depression risk? Okay, so you're partially right, but there's one thing that's missing in this picture. So I'm going to start with a bit of background. As we know, serotonin is involved in mood and mood regulation, but the results for this are very, very mixed. You can't really make a strong case that like one gene related to serotonin is related like in a one-to-one mapping sort of ratio to depression. So looking specifically at the serotonin transporter polymorphism, this determines how much serotonin is taken back up into the presynaptic neuron. That's not all it does, but that's part of what it does. So to address this question, for the serotonin transporter gene, people can have 2 alleles, a short or long allele. So you can have short alleles, short long alleles, and then long alleles. So the short allele is related to slower reuptake of serotonin into the presynaptic neuron. So you're right there. However, the serotonin genes only relate to depression when they're moderated by life stress. Okay, so it's not just that like the serotonin gene is related to depression. It's more like it's something about having short alleles plus having life stress that increases risk of depression. So you need both things. So you need the alleles that are shorter, which are related to slower reuptake of serotonin, plus the stress to increase risk of depression. So it's not just the short alleles. That's not all of the story. There were 2 studies that covered in class, Candler et al. And Caspi et al. They had slightly different results regarding whether you need 1 or 2 short alleles plus the stress to increase risk of depression. So if you want to know more information about that, take a listen. Dr. Weinberg's lecture looking at that. Okay, so that was the first part of the question. Second part of the question was like, isn't the whole point of treating depression with SSRIs the fact that they inhibit serotonin reuptake? Yeah, you're right. SSRIs do aim to reduce reuptake of serotonin to allow more time for it to be in the synapse to bind to the postsynaptic neuron, and we do often use SSRIs to treat depression. However, it's been found that people with a short allele respond less well to these antidepressants. So people with a short allele, SSRIs or antidepressant treatments in general don't really work as well for them. So it might be the case that like SSRIs don't work for these individuals specifically. Okay, so the next question asked about the Schultz et al., the famous Schultz et al. Macaque monkey study. The question is regarding the study in the image below, and the image is just the slide that was up on the screen when Dr. Weinberg was talking about it with the monkey and then the dopamine firing. So in the study in the image below, what's the difference between reward anticipatory and reward predictive cues? We said that there were abnormally high activity in the ventral striatum during these. Does it mean that there's increased activity during the actual cue, but also after the cue is given? So the entire time leading to the actual delivery of the reward. Okay, so I think this individual is talking about 2 different things at once. So I'm going to try to separate the 2. Maybe that's where the confusion is coming from. So I'm just going to address the Schultz et al. Study first. So in the study, as a lot of you know, I'm just going to quickly go through this again. These monkeys were seated in a seat and they were given juice rewards. And the study measured the rate of firing of dopamine in the midbrain. So when the reward was first delivered, you see this increase of dopamine in response to receiving the juice reward itself. And then the monkeys eventually learn which cues predict the reward, and then the dopamine activity happens after the cue indicating that the reward is coming. So the dopamine activity shifts to the reward predictive cue. And then if you deliver the cue, but not the reward, you still get this burst of dopamine activity after the cue, but then when the monkeys don't receive the reward, you see this depression in dopamine activity when they don't get the juice reward itself. So there's this decreased firing when they expect a reward, but they don't get it. So that's the first part, and the study looks at reward predictive cues. And then Dr. Weinberg sort of shifts and starts talking about bipolar disorder. And she says, this is where she says that there's abnormally high activity in the ventral striatum during reward anticipation and during reward consumption, and also for reward predictive cues. So I think this is what the question is asking. I'm not entirely sure, but hopefully this helps anyway. So basically, what this means is that in individuals with bipolar disorder, there is dopamine activity that increases during a period of anticipating a reward. And there's also increased activity to the cue predicting the reward, suggesting that the reward is imminent. So there's increased activity during reward anticipation and to reward predictive cues. However, these are studies done in people measuring activity levels with fMRI. So this is looking at increased fold activation in the ventral striatum. So the macaque monkey study and the studies with bipolar disorder are two different things. They're very similar, and their results are consistent with one another, but I think maybe this is where the confusion was stemming from. So basically, yes, in bipolar, there seems to be abnormally high activity in the ventral striatum during reward anticipation and also following like cues that predict that a reward is coming. Okay, and I got a similar question. If we say that depressed people are deficient in anticipatory reward processing, does that mean that they will have lower dopamine firing even when it's just a cue and they don't know if the reward is delivered or not? Okay, so Dr. Weinberg mentioned that depressed people can still enjoy rewards, so there doesn't seem to be any deficits in consumatory reward processing, but individuals who are depressed might show deficiencies in anticipatory reward processing, so they don't really find the anticipation of a reward very rewarding. So to answer this question, does that mean that depressed individuals would have lower dopamine firing even when it's just the cue and they don't know if the reward is delivered or not? Theoretically, yes. Based on the findings of the monkey study, I would guess that if depressed individuals have deficiencies in anticipatory reward processing, then they would likely react less to the cue predicting that a reward is coming. Okay, next question is, could you please explain the results of the Weiss et al. 2012 study where the use of either a human or a robot gaze was used to direct or misdirect attention? It's not clear to me what matters most for people not on the spectrum. Is it gaze direction if human intention can be attributed to it? Okay, so I'm just going to address what happens with neurotypical individuals who are not on the spectrum, because that seems to be where the confusion is. Okay, so when you have, basically, the premise of the study is that you have these viewers, and the viewers are trying to like guess where a target is going to show up on the screen. And then along with the target comes a face, and the face is either pointing toward the target or pointing away from the target. So neurotypical people are faster to identify the location of the target when a human face is looking at the target. So we tend to use the human gaze to guide our own gaze to find the target quickly. However, neurotypical individuals show deficits, so they are slower at identifying the target when the human gaze is away from the target. So we tend to look where other people are looking, even if it doesn't help us identify the target. So that's the first part of the study. In the second part of the study, the participants were told, or sorry, I take that back. So you don't see this if it's a robot instead of a human face on the screen. So if you have a robot whose face is pointing toward the target, And then a robot whose face is facing away from the target, individuals who are neurotypical will not get distracted by the robot face facing away from the target. So they don't show this slowing in finding a location if the robot is looking away from the target. So that is in contrast with the human face. They do display that slowing when it's a human facing away from the target. So that's the first part. The second part is the experimenters told the participants that someone in the other room was controlling the robot's gaze. And after participants were told that the robot's gaze was being controlled by a human, then we see that deficit again, where the robot gaze does distract people. And if you have a target and then the robot face is facing away, then people are again slower at identifying the target in that case. It's the attribution of the intention of the gaze that's important. If you attribute human agency to the gaze, then you will attend more to that information because we're biased toward attending more to that human gaze. So if people believe that a human was controlling the direction of the gaze, then they're faster to identify targets when the face is looking toward the target and slower to identify targets when the face is looking away from the target. Okay, so I hope that helps a little bit. Okay, next question is, what's the difference between a PTSD sign and a PTSD complication or sequel? How do we recognize each? It seems to me that they're both need to only be seen in people with PTSD and are very similar. Okay, so basically a PTSD sign is a manifestation or product of PTSD, aka a PTSD symptom. So a PTSD sign is synonymous with a PTSD symptom. You're right, it's only observed in people with PTSD. Basically what happens is someone will start having PTSD and then you'll start having this PTSD sign or abnormality at the same time. So that's a sign. When we're talking about PTSD sequels or complications, we're talking about an abnormality that is the product of the PTSD. So PTSD is causing the thing. So in the case of a PTSD sequel, generally the course of the abnormality gets worse over time. The longer you have the PTSD, because PTSD is causing the abnormality, the worse the abnormality gets. So as you get more ill, the abnormality becomes worse. Okay, so those are the differences between the two. A PTSD sign just kind of co-occurs with PTSD, whereas a PTSD sequel is the direct product of PTSD. Okay, next question is, can you have abuse without dependence in AUD? So in DSM-4, there were two types of alcohol use disorders. One was alcohol dependence, one was alcohol abuse, and the DSM-4 made a distinction between dependence and abuse. So yes, you previously could be diagnosed with alcohol abuse, but not alcohol dependence. However, now the DSM-5 no longer has this distinction. So there is no more distinction between abuse and dependence. They're pooled together into a single disorder of AUD. And like the symptoms are slightly different. So, and the prevalence rates that were presented on that slide are probably from the time when we were using the DSM-4 to diagnose abuse and dependence, but that's not the case anymore. Okay, next question is, the prof talked about ketamine, one dose can have long-lasting effects, aka in 7 days it stays low, but then she said on the limit of ketamine slide that it's short-lived. Isn't that contradictory? No, it is not, and I'll tell you why. So this question is about ketamine for treatment-resistant depression. Basically, what Dr. Weinberg said is that ketamine is fast-acting, so the effects kick in very quickly. After one single dose of ketamine, 24 hours later, on a self-report depression scale, the ketamine group reported much less depression symptoms. And this is just to address the question, one single dose of ketamine led to sustained improvement in depression symptoms for a few days after. So the effects of ketamine on depression seems to be long-lasting. So even after a couple of days, the depressive symptoms still stay low. When it is short-lived, like when Dr. Weinberg mentions that ketamine is short-lived, she means like in the system. So physiologically, as a substance, ketamine is short-lived in the system. People would need to regularly visit the hospital to get another ketamine dose because in like a medical setting, you only receive this ketamine dose through an IV. So it's short-lived in the system. You would have to keep revisiting the hospital every couple of days. So that's what that means. Okay, in the Klerman and Weissman graph in lecture 5, there doesn't seem to have an increase in life prevalence as age cohort goes up. It's just because the graph isn't completed. So in the graph does show that people born after World War II do have higher rates of depression and earlier onset of depression. The Klerman and Weissman study looked at many different studies looking at lifetime prevalence rates of depression, and you do see this increase across age cohorts, and you see an increased rate of depression for all age cohorts born after World War II. The rates are now leveling off, but rates tend to increase over time. So that's what the graph is showing. Lifetime prevalence does increase as age cohort goes up. Next question is there any change from DSM-4 to DSM-5 in the criteria for GAD? Nope, not that I know of. There are no changes. Next question, did phobia split into 3 categories in DSM-4 or DSM-3? It's DSM-3. So phobia was split into 3 categories in the DSM-3. Next question is agoraphobia still under phobia, or is it under panic disorder now? It says that it's removed from phobias in DSM-3, but then in class we talked about phobia having 3 types. Okay, so in the DSM-5, agoraphobia is actually now its own diagnostic category. So it's not under phobia or panic disorder. It's not under any other category. It's a separate thing. Agoraphobia can be diagnosed with or without the presence of panic disorder. So if someone has panic disorder with agoraphobia, they just get 2 separate diagnoses. You diagnose panic disorder and agoraphobia. So it's not under phobia anymore. It's now its own diagnostic category. Next question is how to distinguish between situational phobia and OCD. So for instance, the obsessive thought that the plane is going to fall, is that not extreme enough? Okay, so obsessions and situational phobias are quite different things. Obsessions, according to the DSM, are defined by these 2 things. So the first thing is that there's these recurrent and persistent thoughts or urges or images that are experienced as intrusive and unwanted. The second thing is that the individual tries to suppress the thoughts, ignore the urges, or tries to neutralize them with another thought or action. So the DSM actually says, like individuals with OCD, individuals with specific phobia can have a fear reaction to specific objects or situations. However, in specific phobia, the feared object is usually much more restricted and the rituals are not present. So that's the difference. Like with specific phobia, you'll have this fear about a very small restricted sort of thing, and you won't have these rituals that often accompany OCD obsessions. So those are the differences. Okay, next question is AUD under SUD? So the short answer is yes, it is. So alcohol use disorder and substance use disorder are both under the DSM category substance-related and addictive disorders. And technically, SUD refers to recurrent use of one of the substances that you can get diagnoses for that result in significant adverse consequences. So the substances of abuse are divided into 10 different categories, of which alcohol is one. So so basically AUD is under the substance use disorder category, but it's a separate diagnosis. So AUD is in the alcohol-related disorder section and is a separate diagnosis. Okay, next question is anorexia comorbid with avoidant or OCPD? Yep, it can be. I'm not sure how common it is, and the DSM doesn't specifically mention a particularly high comorbidity specifically between anorexia and these personality disorders, but there's nothing to prevent both diagnoses from happening at the same time. So anorexia can absolutely be comorbid with avoidant or OCPD. Is there evidence for distinct neural signatures for BPD? I would be hesitant to say at this point that there's distinct neural signatures specific to BPD. But there is some evidence that there are certain neural activation patterns that seem to be more common in individuals with BPD compared to controls. So for instance, we talked about the Baskin-Summer et al. Study in 2015 that looked at individuals with BPD and then controls without BPD. The study found that there was increased amygdala activation in individuals with BPD when viewing fearful and happy faces. Similarly, in a Dottinger et al. Study in 2003, patients with BPD showed greater left amygdala activation when they were seeing neutral, happy, sad, and fearful facial expressions compared to control. So there is increasing evidence that perhaps there are some neural signatures that are typical of BPD versus control, but at this time, like, I'd be hesitant to say, like, yes, absolutely, there are distinct neural signatures specific to BPD. Okay, Dr. Weinberg mentioned that baclofen is a GABA agonist and can therefore replace the effects of alcohol. I don't fully understand this because she also said alcohol is a GABA antagonist. How does baclofen replace the effects of alcohol if it doesn't inhibit GABA? Okay, so there are a couple of different things that I want to address in this question. I'm going to start simple with GABA. So GABA plays an inhibitory role in the brain. It reduces neuronal excitability, so it inhibits dopamine neuron receptors. It acts at inhibitory neuron synapses, in the brain. Alcohol is a GABA agonist. It's not a GABA antagonist. So alcohol is a GABA agonist. It binds to the same receptors, it mimics the effects, and it binds to the same receptors to inhibit activity. Again, it's not an antagonist, it's an agonist. So baclofen replaces the effects of alcohol because baclofen is also a GABA agonist, and alcohol is a GABA agonist too. So basically, both alcohol and baclofen, act like GABA and initiate the same response as a substance. So that's how you can replace the effects of alcohol with baclofen, because they have similar effects. They both act like GABA. However, I want to point out that baclofen doesn't necessarily inhibit GABA. It acts like GABA. Okay. Catastrophizing versus overgeneralization. These two concepts are very similar, and in the examples given, seem interchangeable. Can you explain the key difference between the two? Yes, I can. In 1 second. Examples given seem interchangeable. Okay. So catastrophizing is basically when someone exaggerates the importance of their problems or their errors. So just to give an example, say you start at a new job and you're meeting your new boss for the first time, and then like 5 minutes later, you forget that you've met them and you run into them in the hallway and you introduce yourself again the next time you meet them. Your boss points this out. They're like, we already met. And you're super embarrassed and you're freaking out. You're thinking that they're going to hate you forever. They're never going to promote you. And in fact, they might as well just fire you on the spot. And they probably will actually fire you on the spot. And they're just going to tell everyone how dumb you are and make your life a living hell. And you'll never be able to live this down. That's an example of catastrophizing. So you're taking this small mistake that you made and you're exaggerating its importance. So you're saying that, like, because of this small mistake, I'm going to be fired. Everyone's going to be thinking that I'm super stupid. I'm never going to be able to live this down and show my face ever again. So overgeneralization is slightly different. It's when you see one negative event as being a pervasive pattern that will always or never happen in your life. So just to illustrate this, I have another example. So for instance, you walk into work and the first thing you do is spill coffee all over your shirt. And after you spill coffee, you think, oh, you're always doing things wrong. You'll never do things right. You'll always just be this gigantic klutz. So let's just kind of look at both of these examples, and I'll kind of talk through why the first example is not overgeneralization and the second example is not catastrophization. So the first example isn't overgeneralization because you're not saying, I screwed up with this boss. I always screw up. I'll never be good in social situations. You're just spiraling down about one single situation. So you're over-exaggerating and catastrophizing one single mistake that you made. You're not saying like, oh, this mistake is evidence that everything will always go wrong. On the flip side, the spilling the coffee on your shirt and thinking you're always doing things wrong, you're never doing things right, isn't catastrophizing, because you're not saying the fact that I spilled this coffee on my shirt is the worst, it's a terrible mistake, this will have a massive consequence, my entire day is ruined. You're just using this one thing as proof that, in general, you will screw everything up. So hopefully that clarifies things a little bit, that are a bit more ambiguous, and some examples that are a bit more clear-cut about catastrophizing versus overgeneralization. But they are two distinct different things, and hopefully those examples can help out a little bit. Okay, I just wanted to clarify what the BMI criteria is for anorexia. There seems to be a mixed consensus among the class. Okay, I'm not sure what the mixed consensus is, but basically, by definition, to receive a diagnosis of anorexia, you need to have low weight status. So you need to be underweight by definition. The actual criteria in the DSM-5 addressing this is a restriction of energy intake relative to requirements, leading to a significantly low body weight in the context of age, sex, developmental trajectory, and physical health. Significantly low weight is defined as a weight that is less than minimally normal, or for kids and adolescents, less than minimally expected. So the criteria for anorexia nervosa themselves don't specify a certain BMI that people need to be. So individuals who are receiving a diagnosis of anorexia do need to have significantly low body weight for their developmental age. And that ultimately is up to the diagnosing clinician. But the DSM does kind of give guidelines. So when you give a diagnosis of anorexia, you specify what the current severity is. And the current severity is based on BMI, basically. So the ranges that the DSM gives come from the World Health Organization categories for thinness in adults. Basically, the World Health Organization has deemed that anyone with BMI less than 17 would be considered to have significantly low weight. So these are just guidelines, though. People with BMIs over 17 can be diagnosed with anorexia. Because different people have different medical histories, some are still growing, you can't really make a set cutoff point for BMI that will work for everyone across the board. So ultimately, it's up to the diagnosing clinician to make the call. Oftentimes, it's very clear that someone is below the weight that is expected. Other times, it's not so clear cut. And you can use the guidelines that are provided in the DSM, which again is that anyone with BMI less than 17 is considered to have low weight, but that's not a set cutoff point. That's just a guideline. Okay, the next question is, what's the most common anxiety disorder, and what's the actual age of onset for GAD? So I'm gonna preface this by saying that you don't need to know exact prevalence rates because they depend on the country that the study was done in, the study you're looking at, and so on. According to your textbook, specific phobia is the most common anxiety disorder. It has a 12.5 lifetime prevalence. However, GAD is the most commonly diagnosed disorder in primary care, and it has a 6% lifetime prevalence. And then social anxiety has a 7% lifetime prevalence. As for the GAD question, the average age of onset of GAD is about 31, as is listed in the chart on Dr. Weinberg's slides. But the onset of GAD is typically gradual, so it comes on very slowly, and typically it starts in the teenage years. However, the prevalence of GAD peaks in middle age, according to the DSM. There's a very, very broad range of ages for onset, but onset is very rare before adolescence. So long story short, the average age of onset is about 31, but it typically starts in the teen years. And again, these are averages. Different people will have GAD onset at different age, so there isn't an actual age of onset. These are just averages, and typically people, the average age of onset is 31. Okay, next question is, I'm having difficulty placing the prevalence of all the disorders we've covered. From what I have so far, anxiety disorders are most prevalent, then unipolar mood, then substance abuse, then eating disorders, personality disorders, autism spectrum, and then schizophrenia is the least common. Can you please clarify also, if it had to be put into each individual disorder, what would be the most prevalent and least prevalent? Okay, so again, this is tricky because according to different studies, there are different prevalence rates, but I'll do my best. So according to your textbook, anxiety disorders are most common. The prevalence is as high as 31%. So you're right there. Anxiety disorders are most prevalent. And then unipolar mood disorders seem to have a prevalence of 16 to 17%. Alcohol abuse, prevalence is about 13%. Eating disorder not otherwise specified is around 11%. So far you've got the order right. But then for personality disorders, I would be hesitant to lump them all into one group together because there are different prevalence rates for each. So for instance, in the DSM, schizoid personality disorder prevalence is around 3%. And then borderline PD, according to your lecture, is 1 to 2%. So even within this category of personality disorders, you see these different prevalence rates. So you can't really lump these together or rank order them necessarily. As for schizophrenia and autism, schizophrenia seems to have a 0.7 to 1% prevalence rate, and then autism has about a 7.6 per 1,000 or 14 per 1,000, depending on what study you look at, prevalence rate. So I would flip those two. Schizophrenia seems to be more prevalent than autism. And then in terms of individual disorders, I'm not sure about the least prevalent. There are a lot of disorders that have very, very low prevalence rates, and I'm not sure which is the least prevalent. But in terms of the most prevalent, major depressive disorder has the highest lifetime prevalence rates. Yep. How would you make a differential diagnosis between social phobia and avoidant PD? What are the distinguishing features? Okay, this is actually a really good question. They are quite similar, and the DSM even straight up says there appears to be a great deal of overlap between the two, so much so that they may be alternate conceptualization of the exact same thing. So I'm going to go through criteria for both of them and then point out a couple of differences while I go through and then at the end. So avoidant PD is a pervasive pattern of social inhibition, feelings of inadequacy, and hypersensitivity to negative evaluation, beginning by early childhood and present in a variety of contexts. So I'm going to pause there for a sec. Beginning by early adulthood, that's important. That is specific only to avoidant. Also, the fact that this pattern needs to be present in a variety of contexts is also specific to avoidant PD. So that's two things right off the bat that are different. So this pervasive pattern has to be indicated by 4 or more of the things I'm about to list. 1, the individual will avoid activities that involve significant interpersonal contact, specifically because they're scared of criticism, disapproval, or rejection. 2, the person is unwilling to get involved with people unless they're absolutely certain that the other person's going to like them. 3, the person shows restraint even in very close intimate relationships because of the fear of ultimately being shamed or ridiculed. 4, the person is preoccupied with being criticized or rejected in social situations, which is actually quite similar to social phobia, so that one is similar. Number 5 is that this individual is inhibited in new interpersonal situations because they feel like they're very inadequate. Number 6 is that they view themselves as socially inept, personally unappealing, inferior to others. And then the last one is that they're unusually reluctant to take personal risks or to engage in any new activities because they may prove embarrassing. So you need 4 of the things that I just mentioned. The central part of avoidant personality disorder is this fear of criticism, disapproval, and rejection. They think that others are always critical and disapproving, like across the board. So even if individuals with avoidant PD might have known someone for a very long time, they might consider them like very close friends, they will still, in the back of their mind, still kind of expect that ultimately this close other will reject them. So that's very characteristic of avoidant PD. Even in very close relationships, they have a hard time not feeling like they're going to be criticized or rejected eventually. So they kind of tend to keep people away at arm's length, even if they're close to them and they've known them for a very long time. Okay, so that being said, let's look at social anxiety disorder. It's marked fear or anxiety about one or more social situations. So again, social anxiety disorder can be diagnosed if an individual shows marked fear about one social situation. So that, again, is one way that these two conditions are different. So it's marked anxiety in one or more social situations where the individual is exposed to possible scrutiny by others. And then the individual fears that he or she will act in a way or show anxiety symptoms that will be negatively evaluated. So a lot of the times, people with social anxiety disorder might have a fear of blushing and other like shaking and so on. The social situations almost always provoke fear. Social situations are avoided and they're out of proportion. The fear is out of proportion to the actual threat. And the fear, anxiety, or avoidance is typically lasting for 6 months or more. So those are the criteria for social anxiety disorder. Now, just for like a couple of more like distinguishing features between the two, individuals with avoidant personality disorder tend to have a broader avoidance pattern than those with social anxiety disorder. So for instance, you can have someone with social anxiety disorder who is only scared of public speaking. So they have this like marked fear of speaking in front of a group of people. You wouldn't really see that with avoidant PD, because with avoidant PD, they like across the board in multiple situations, multiple contexts need to show this pattern of avoidance and anxiety in social situations. So that's one way to think about the differences. They tend to differ in symptom severity. Avoidant PD seems to be like a lot more severe. And in avoidant PD, even in close relationships, they avoid getting too close. So this is another way that you can distinguish between the two. In social phobia, individuals with social anxiety disorder, they might get comfortable with certain people. They tend to have close friends, family members, and so on that they're comfortable with and they can talk to, and they're fine in those contexts. They can engage with these people. But with avoidant personality disorder, it's not really like that. Like they may have a couple of people that they're closer to, but they tend to keep them at arm's length because, like, in the back of their minds, they fear ultimately being rejected, no matter how close they are to those people. Okay, could you please go over the main differences between antisocial personality disorder and psychopathy? I sure can. So let's start with antisocial. Basically, the main difference between the two is the way that we conceptualize them. So with antisocial, we diagnose antisocial personality disorder based on observable behavior. And then with psychopathy, psychopathy more refers to the emotional and interpersonal features and not so much the observable behavior. So antisocial personality disorder is a pervasive pattern of disregard or violation of the rights of others that begins in childhood. They don't conform to social norms, they lie, they're impulsive, they're aggressive, they have disregard for other safety, they're irresponsible. So that's what antisocial looks like. So criminal behavior is central to the DSM-5 diagnosis of ASPD. And again, it's like very based on behavior. On the flip side, psychopathy refers to more like the psychological aspects. So psychopathy refers to shallow affect, lack of empathy, lack of remorse. These individuals tend to be deceptive and manipulative and superficially charming. They might use other people, they might be chronic liars. So in psychopathy, criminal behavior is one piece, but it's more about the psychology than the behavior. So for instance, like if you have someone who, like you can have people with antisocial personality disorder who are also psychopaths, but you can also have like psychopaths who have this shallow lack of empathy, superficial charm, manipulation without the deviant criminal behavior, and vice versa. So the diagnosis of antisocial personality disorder completely misses non-criminal psychopathy. Can you please go over clarifying the different genetic pathways of antisocial personality disorder? Yep, so aggression is very genetic. So for one example, there can be deficits in the MAOA gene that degrades serotonin, dopamine, and norepinephrine. The more MAOA people have, the greater degradation of serotonin, dopamine, and norepinephrine. And then the less MAOA people have, the more serotonin, dopamine, and norepinephrine there is, and the more these neurotransmitters are available, that's associated with impulsivity and aggression. So less MAOA is associated with higher impulsivity and aggression. But that's not the whole story. Again, it's all about interactions. So the MAOA gene is a diathesis. It's not just a direct link to aggression. While most maltreated kids don't go on to engage in criminal behavior, it's a risk factor. So depending on your level of MAOA activity and your like environmental experience, you will be at more or less risk of antisocial behavior. So there was a Caspi et al. Study looking at activity of MAOA and its interaction with maltreatment. So when kids have no maltreatment or probable maltreatment, they have similar levels of antisocial behavior. But when you look at individuals who have experienced severe maltreatment, low MAOA is associated with much more antisocial behavior. So, and again, like low MAOA is associated with less degradation of serotonin, dopamine, and norepinephrine, and is associated with aggression. So you need both severe abuse and the genetic predisposition to develop antisocial behavior. So it's the interaction between these two variables. Also, individuals who have antisocial personality disorder or more antisocial behavior in general tend to have had a more negative upbringing. So a lot of the times they have experienced adverse parenting. For instance, aggressive parenting may create a negative environment, but if you have aggressive parents, then they've probably also passed down those aggressive genes. So you have this genetic predisposition for antisocial behavior, but also this environment that promotes antisocial behavior. Also, you can have assorted mating. So if two aggressive people have a child, that means they're passing down this genetic predisposition for aggression, but they also might create an aggressive environment again. And they might have a hard time being consistent with their disciplining and may not be able to have the resources that it takes to cope with having kids who are aggressive. Also, individuals with antisocial personality disorder can make antisocial friends. So again, it might be that like individuals who have genetic predispositions for antisocial behavior then make a more antisocial environment for themselves by making antisocial friends. Okay, and then there was a Cattery et al. Study in 2005 that showed that if a kid was adopted and the kid had one biological parent with antisocial, they were more likely to develop antisocial personality disorder regardless of the status of the adopted parents. So regardless of whether their parents had antisocial PD or not. However, these kids with one parent with ASPD were even more likely to develop ASPD if your adopted family is unstable and high in conflict. So the risk is even higher if you have the gene and the environment risk factors. So basically, your genes moderate susceptibility to the environmental influences for developing antisocial personality disorder. Okay, I'm going to try to talk really quickly. I have so many more slides. Why would treatments be effective in reducing rates of criminal behavior and antisocial, but not psychopaths? They are more likely to reoffend using social skills training. Would they be ineffective for both? So no, they wouldn't be ineffective for both. Basically, studies have found that treatments might be useful for antisocial behavior. SSRIs reduce aggression. So in criminals with antisocial tendencies, treatments do seem to reduce rates of reoffending, which is really good. So some treatments do work. However, the evidence is very, very weak for psychopaths. So treatment for psychopathy seems to make for more effective psychopaths because, again, like antisocial personality disorder is very centered around like antisocial behaviors, but psychopathy is something psychological. So treatments for psychopathy focus on empathy and social skills and how to understand people in an attempt to try to, make people be more empathetic towards other people. However, if you lie and manipulate, as is common in psychopathy, and you're taught about people's emotions and empathy and how people think, you might just learn how to better manipulate people because then you are given the tools to understand their emotions better and can then manipulate their other people's emotions better. So that's why the treatment outcome for psychopathy is bleak, and it might actually increase the risk of reoffending. So treatment may work for antisocial personality disorder, and it can teach people to display less antisocial behavior. If you want more information about this, check out the Liberia study by Blattman et al. That Dr. Weinberg talked about in class. But the treatment is not the same for psychopathy, because it's characterized more by psychological and emotional aspects. So the treatments are not ineffective for both. The treatments, some work for antisocial personality disorder, but not for psychopathy. Okay, next question is, could someone be diagnosed with bulimia nervosa if they met all criteria, but the only compensatory behaviors they engaged were non-purging, so just excessive exercise, or is only the purging ones that are considered compensatory behaviors in bulimia? So yes, someone can be diagnosed with bulimia nervosa if they only engage in non-purging behaviors. This is in your textbook. The DSM-5 B criteria for bulimia is that individuals have recurrent inappropriate compensatory behaviors in order to prevent weight gain, such as self-induced vomiting, misuse of laxatives, fasting, or excessive exercise. So if someone has excessive, and that's their only compensatory behavior, they can be diagnosed with bulimia. Could you please go over clarifying the helplessness versus hopelessness theories for depression? So basically, learned helplessness is an animal model. So Seligman's original study is where you put the dogs in a box and the experimenters could shock the dog's feet. If the dogs could escape the shock, then they would just learn to jump to the other side. And if they were allowed to escape, like the dogs who were shocked were not displaying symptoms of depression. But if the dogs could not escape the shocks, so there was no escape or no way to control the shocks, they would basically just give up. The dogs would lay down and they would just kind of feel the shocks and give up. The dogs would be lethargic, they would eat less and be depressed. So basically, the original learned helplessness model is that depression is a result of having a history of early helplessness. So if you have been in situations where you can't escape and you have no control over and over and over again, you kind of learn that there's no point in coping or trying to stop bad things from happening because the bad things will happen anyway. You have no control over anything. So you stop trying to cope with the bad things, you stop fighting because it doesn't change anything. So in this theory, depression is basically an adaptation to negative life circumstances. And then in the 1970s, it was sort of revamped because the researchers recognized that not everyone will just give up when exposed to uncontrollable stressors. So the question now was, what are the cognitive mechanisms that will lead some people to respond with helplessness while other people to not respond with helplessness? So when people are exposed to stressors, they tend to ask, why is this happening? And the answer to this question is what determines how people are going to react to uncontrollable stress, and it is going to determine whether they'll become depressed. So these attributions can be external or internal. So if you attribute the situation to something bad about yourself, then that's more common in depression. The attribution can be global versus specific. So if you attribute that this bad situation will always be the case, all situations will be uncontrollable, the world is bad in general, that's also associated with depression. And then the last sort of pair of attributions that you can make is stable versus unstable. If you think that all situations will be terrible, you'll fail at all the things always, that again is most commonly seen in depression. So people who attribute negative situations to internal, global, and stable causes, they're more likely to be depressed. And finally, the hopelessness theory is sort of like the current version of learned helplessness. This came out of a recognition that depression is very different. So there are very many subtypes of depression. And this theory says that hopelessness depression, a subtype, is caused by hopelessness. So people with hopelessness depression have this inferential style where you draw conclusions about bad situations that are stable, global, and internal. So if you have this inferential style where you think that these negative situations are stable, they will always be the case, global, all situations will be bad, and internal, this situation is bad and that's because of me, this will then lead to hopelessness, which will then lead to depression. So it's not that like stable, global, and internal attributions lead straight to depression. Hopelessness is now introduced as a middle step here. Yep. However, it's important to note that it's not super clear if these ways of thinking cause depression or are part of depression. Okay, next question is, would we consider anxiety and depression secondary to a personality disorder? I think we said that axis 1 disorders are the real primary problem, so I'm not quite sure. Okay, so we actually don't consider disorders axis 1 or 2 anymore. DSM-5 got rid of the system of classification. What disorder you consider primary or secondary will depend on the patient. So the main diagnosis will sometimes be anxiety or depression, but sometimes it'll be the personality disorder, depending on what's most impairing to that patient or that client and what you need to address first. Okay. The next question is, I'm not sure about the sequence of events for Marshall and Hand's biosocial model for borderline personality disorder, as it was explained in class. Okay, so people tend to have a biological, genetic or otherwise, to experience emotions very intensely. So even as babies, right off the bat, these individuals who are at risk for developing borderline later on are very emotionally reactive. They feel things very deeply. And then this, like emotional reactivity to the environment, is combined with an invalidating family environment. Instead of learning how to effectively deal with strong emotions, like people generally do as they grow up in a stable and validating family environment, instead they become more emotionally dysregulated. So it's not that people necessarily have a genetic predisposition for the dysregulated emotions, it's that they have a predisposition to feel emotions deeply, be more sensitive, and take longer to recover from the deep feelings, as well as maybe struggling a little bit to contain their emotions. And then when they're exposed to this invalidating environment, that's when their emotional systems become even more dysregulated and even more dysfunctional because they've never learned how to control their emotions. It's not pathological to feel things deeply. It becomes pathological when you can't control the emotional reactions. And that's what the model says. Can gray matter loss in schizophrenia be a vulnerability factor? Can it be an endophenotype? So basically, Thompson et al. 2000 found volume changes over time in people with and without schizophrenia. We don't really know if studies looking at whether people vulnerable to schizophrenia but haven't developed schizophrenia yet also show this vulnerability factor. So we can't really be sure if it's a vulnerability factor. But there is a study looking at monozygotic twins that are discordant for schizophrenia. So both twins show this deterioration in volume. So even the twin without schizophrenia also shows this deterioration in volume. So this does kind of suggest that it might be a vulnerability factor. So more research is still needed, but yeah, it could be a vulnerability factor. It could be an endophenotype for schizophrenia, but at this point in time, we can't know for sure. More research is needed. In autism, slide 51, it says secondary to chromosomal abnormality or single gene disorder. Does that mean that ASD is not primarily caused by genetic influences? So it's clear that there's a genetic component to ASD, moderate heritability. That's what the studies have found. So about 60% genetic. However, only about 10% of kids with ASD have an identified genetic chromosomal or neurological disorder. So we're not able to explain a lot of the genetic variances because like the remaining 90% of kids of the cases have an unknown genetic cause. So that's not quite right. Dr. Weinberg says that autism spectrum disorder is likely secondary to a chromosomal abnormality or single gene disorder. A secondary illness is one that stems from or follows an earlier condition. So ASD does have a large genetic component, but it's likely a secondary illness that results from another condition that came from a chromosomal abnormality or single gene disorder. Next question is there hyperexpansion in all the high-risk infants in Hazlitt study or just those who went on to be diagnosed with autism? All of the high-risk infants in Hazlitt et al. 2017, so infants with older siblings on the ASD symptoms, all of them show hyperexpansion. Okay, so Prof said in class that ACE inhibitors is the most commonly prescribed medication, but I don't think it's the most according to the graph, slide 3 in psychopharmacology. I'm not sure what happened there, but the main point of that slide, the takeaway message is that beta blockers and antidepressants are the second most prescribed medications in Canada. What's the difference between severe depression and chronic? Are severe usually chronic? So basically, severe depression is depression that is on the most severe end of the depression spectrum. That is not very helpful, but basically, a lot of the times, people with severe depression have severe suicidality, perhaps suicide attempts, great difficulty getting stuff done. They might live in complete isolation, total loss of appetite, struggle a lot to get out of bed, and so on. So, like, it's very, very severe symptoms. However, chronic depression is depression that lasts a very long time. So this is the case where it's like severity versus chronicity. It's not the same. The difference is that severe depression is like individuals with very severe symptoms, and then chronic depression is depression that lasts a very long time. You can have people with both chronic and severe depression, but you can also have people just with severe depression. So for instance, you can have one episode lasting 5 months that's very, very, very severe. Or you can just have chronic depression. So an individual who has multiple long episodes over like but the episode aren't very severe. Okay, so in Mayberg's study, this is about deep brain stimulation. When she gets individuals' coordinates for each patient, does that mean she essentially personalizes the treatment? Mayberg and colleagues got the people's specific coordinates for where their subgenual cingulate is. This region is a vulnerability marker for depression, and that's the region that they stimulated in this treatment. So for each person, Mayberg and colleagues outlined this region and found the specific coordinates. So the treatment itself was the same, but they just measured where this region was exactly. Brains are not all exactly the same, so this region wouldn't have had the same location in everyone. So in Mayberg's study, like they found where every single person's region was specifically. She didn't necessarily personalize the treatment. It's just that she found exactly where everyone's subgenual singulets for. Is BPD egosyntonic? So generally we talk about egosyntonic and egodystonic as being specific to certain behaviors or emotions. BPD is a lot broader than that. But since it's a personality disorder, and the emotions and cognitions in the case of BPD are part of the person's like way of being and style of being, I would guess so. Yes, I guess BPD is egosyntonic, but again, like I'm hesitant because I don't really want to put that label on an entire disorder. We generally talk about egodystonic and egosyntonic in the terms of specific behaviors and emotions. Okay, so that was it. That was so much talking. Okay, thanks for listening, you guys. Good luck tomorrow. Have a good night.